Hello friends, welcome to Cortex YouTube channel. In this video, I am going to discuss about a case. It's very interesting. Please follow this. Middle-aged male with no past medical history presents with symptoms of indigestion with chest burning and throat tightness over the past 2 weeks, occurring with activity. Okay. Over the past 2 days, he experienced chest burning at rest. He has 25 pack year history of smoking and his father died of MI at the age of 52. So ECG is obtained, cardiac troponins are negative. So before going to ECG, let's analyze this history. See, past 2 weeks, see he is a middle-aged man, chronic smoker. So in the background of history of smoking and clinically significant family history of cardiac death is very important here, and he is having 2 weeks of chest burning and indigestion uh, occurring with activity or exertion, so exertional symptoms, and now with 2 days he is having chest symptoms with even at rest. Okay, some that means there is some change. Now ECG is obtained and cardiac troponins are negative, so it's pointing towards acute coronary syndrome. In that, especially the point that they have mentioned cardiac troponins are negative is your unstable angina. So clinically we are thinking in terms of unstable angina. Let's look at the ECG, what it tells. So assuming that it is taken with normal standardization, let's see any given ECG. You have to know the rhythm first. First thing that you have to comment is rhythm. So how to know, how to comment on the rhythm? For that you have to see lead to rhythm strip. So in that you have to see followings. First one is P wave. Look at this P waves. These are your P waves. These are your P waves. All P waves are looking similar morphologically. Morphologically, when I say morphologically, it is size and shape. So all P waves are looking similar, and all P waves are followed by QRS complexes. These are your QRS complexes, and these are your R wave. So RR interval is equal every beat. Okay. So these all 3 points suggest that there is normal sinus rhythm. So how to know that a given ECG is a normal sinus rhythm? First thing, all P waves should be equal. Second thing, all P waves should be followed by QRS. Third thing, RR interval equal to RR interval, that equals to PP interval. Okay. So when these all three criteria are fulfilled, we can call it as normal sinus rhythm. Okay, this is a normal sinus rhythm. Now after knowing that the rhythm is in normal sinus rhythm, rate calculation becomes very easy. How to calculate a rate? Rate is calculated by 300 divided by number of big boxes between two R waves. So how many big boxes are there? Okay, let's calculate here. So this is one box, two box, three box. See, big box means this one. This is one big box. It has 25 small boxes. So one, two, three, three boxes. Around three boxes. So 300 by 3, it is coming around 100. So it is in the borderline. If you calculate accurately, it comes around 92 beats per minute. Okay. So it is 100. Okay. Rate is also normal. Rhythm is also normal. Now we have to calculate axis. Third thing that you have to comment is axis. So what do you mean by axis? Axis is nothing but direction of major current vector, where it is directed, whether it is directed normally or right or towards left. So in this ECG we have to see axis, and axis is determined by looking at the lead 1 and lead AVF. Let's look at the lead 1. This is lead 1 and this is lead AVF. In that, what you have to see? You have to see QRS complexes, whether they are predominantly positive or predominantly negative. See, positive means anything upward in ECG is positive, anything downward is in ECG is negative. So here it is up, so it is predominantly positive. It doesn't have any negative deflection, so it is predominantly positive. So it is lead 1 is positive. In lead AVF, it has both component, positive component and negative component, but predominantly it is positive. So lead AVF is also considered predominantly positive in this ECG. So when lead 1 is also positive, lead AVF is also positive, Both are positive means it is normal axis. Let's suppose lead 1 is positive, predominantly positive, and lead AVF is negative predominantly. So both are leaving each other. One is going up, one is going down, leaving each other. L for L, LAD, that is left axis division. Let's suppose lead 1 is predominantly negative, that is down, and lead AVF is predominantly positive, that is going up. So both are reaching each other. Reaching each other means R. R for R, right axis division. When both are negative predominantly, that means both are going downwards, that means it is extreme axis deviation. Okay, but in this given ECG we have got normal axis. So far it is normal axis, normal rate, and normal rhythm. So let's look at what is abnormal then in this ECG. Let's look at this. Obviously there are striking features. Okay, there are so many striking features. What are they? Look at this. Look at this. Lead 2, 3 and AVF. Lead 2, 3 and AVF and V2 to V6. What happened here? Look at the ST segment, especially this part. Look at this part. What happened to this part? Let's describe it. See, normally I will draw here normally how it was supposed to be. See, normally it was supposed to be like this. Okay, normally it was supposed to be like this, but what happened here? See, there is depression of J point. J point is depressed. ST segment is also depressed, but ST segment, the shape of ST segment depression is upsloping. It is upsloping. See, ST upsloping ST depression. Okay, look at here. It says ST upsloping depression. It's not horizontal depression, or it is not downsloping depression. It is upsloping depression. Okay, now it is seen in 2,3 AVF. 2,3 AVF represents inferior wall of the heart. So inferior ST depression, that to upsloping and J point depression. Next, it is similar findings are also seen in lead V1, V2 to V6. Look at there. ST is depressed and it is upsloping. Look at here, upsloping ST depression. Okay, so these findings are seen in 2,3 AVF and V2 to V6. So 2, 3 and AVF and V2 to V6, they all show J point depression and ST upsloping ST depression. So these are ischemic changes. They are nothing but ischemic changes. They represent subendocardial ischemia. Subendocardial ischemia. So the thing is, they are non-specific because these findings are non-specific. That means they are not 100% telling that it is because of ischemia, because these findings are also seen in some other condition, that is, let's suppose tachycardia. Any condition that causes tachycardia will have these findings. So why in tachycardia they have these findings? Because what happens, see, with normal heart rate, what happens, your atria, see, let's suppose I will tell you this. Let's suppose this is P wave. This is normal waveform. This is P wave, Q, R, S, T, and this is your ST segment, and this point is J point. Okay, normally atria gets depolarized first. After that, ventricular depolarization happens. See, atrial depolarization is represented by P wave. QRS represents the ventricular depolarization and T represents ventricular repolarization. So where is the atrial depolarization? It is not represented in the ECG because it falls, atrial repolarization falls exactly on the ventricular depolarization. So ventricles are having more muscle mass, so it is atrial repolarization is masked by the presence of QRS, presence of ventricular depolarization. So in tachycardia, what happens? this PR segment or PR interval becomes narrow. So QRS becomes early. QRS means ventricular depolarization happens early, and this atrial repolarization falls little bit away from the QRS, and because of that, see, repolarization is a negative vector. Because of that, there is ST depression and J point depression and ST depression in the initial part. After that, ST becomes normal, that is, it becomes upsloping, and T wave will be normal because T wave represents ventricular repolarization. So you get J point depression and ST upsloping ST depression. Okay, I hope you understood. If you don't understand, please rewatch this video. Okay, next. So okay, this represents ischemia. So in this ECG, the patient is having subendocardial ischemia. So he is in the context of clinical history suggestive of acute coronary syndrome and troponins being negative and ECG showing ischemic pattern. We can diagnose this patient is having unstable angina. So, see, acute coronary syndrome. This patient is having acute coronary syndrome. Acute coronary syndrome is divided into two main things. That is what ST elevation, MI. MI means myocardial infarction, and non-ST elevation acute coronary syndrome, which is further divided into non-ST elevation MI and unstable angina. See, whenever there is word infarction, that means myocardial necrosis has happened, and there will be elevation or presence of positive cardiac troponins. But in unstable angina, there is no infarction, there is no myocardial necrosis, so cardiac troponins will be negative. Cardiac troponins will be negative. So this patient is having unstable angina. I hope you got this video informative, and if you find this video informative, and please like, share and subscribe and share this video among your juniors. Thank you.